A very good evening to one and all. This is Nurus Sabah. I'm a clinical pharmacist working in AIG Hospital, Gachibowli, Hyderabad. I welcome you all to the second session of FCPI Critical Care Medicine Forum. I would first like you to spend 10 or 15 seconds imagining a scenario where a patient is admitted in a medical emergency, is deprived of most vital thing called oxygen and nutrients. Okay, and there is a medical emergency where the doctors are involved. And as a very new clinical pharmacist in an ICU, you do not know of the scene. What do you call it? You hear something called shock, sepsis, or shock there. Did you ever sit back and realized or thought about the definition of shock? A shock which is in regular days, in a regular meaning, or a medical condition. Have you ever tried to differentiate between these two? Well, I was in this space for quite a long time. A definition
Hello. Hello. Hello.
I apologize. Hello, am I audible?
Yeah.
Yeah, I apologize for the glitch. Okay, coming back to the session. So, shock demands a swift and decisive action. Every minute counts in saving lives and preventing irreversible organ damage. Shock contributes to a significant number of ICU admissions and mortality rates. So, here let's delve into the topic and deepen our understanding of the topic called shock by speaker Dr. Shubham. Let me introduce you without a further ado about Dr. Shubham. He is a PharmD graduate from the Government College of Pharmacy, Amravati, Maharashtra. He is currently working as a clinical pharmacologist and EMC coordinator at Jupiter Lifeline Hospital, Pune. He is also a member of Institutional Ethics Committee at Jupiter Lifeline Hospital. He is also a member of FCPI and co-lead Critical Care Medicine Forum. His past work experience include as a clinical pharmacologist and AMC coordinator for 1.5 years at Medicover Hospitals, Nashik, Maharashtra. To add to his conference presentations, he has been a part of Myocon 2023 5th International Conference on Fungal Infections and Mycology Masterclass by Fungal Infectious Study Forum. His areas of interest include infectious diseases, critical care, and clinical pharmacokinetics. I hand over to you, Dr. Shubham.
Thank you, Nuri, for your kind introduction. Am I audible?
Just a minute before we proceed, let me introduce to the guidelines of the presentation, the participant guidelines. Please ensure that you post all your queries at the end of the session. Your questions will be discussed as a Q&A session at the end, or you can type all your questions or responses or comments over there. Can we move on to the next slide? Yeah, and please submit your feedback at the end of the session by clicking onto the icon shown there in the green box. The next slide, please. And as per the information provided in the feedback form, you will be receiving your certificate within 14 days. And it's very important that whatever information you provide will be printed in the certificate. Thank you. Please proceed, Dr. Shubham.
Thank you so much for your kind introduction. And I thanks to FCPI for giving me this opportunity to this introduction to shock. So today's topic is shock. There is no disclosures from my side. So the learning objectives for today's sessions are evaluate and understand the shock. There are various types of shock like distributive shock, anaphylactic shock, then cardiogenic shock. So we will see the types of shocks, mechanisms, and pathophysiology of shock, diagnosis and clinical evaluation, and management of the shock. So shock is a common condition. In ICU, we see most of the patients come in shock, which affects the 1/3 of the population in ICU. So circulatory shock can be described as an acute failure of the circulatory system to supply the peripheral tissues and organ of the body with an adequate blood supply, resulting in the cellular hypoxia. So most often it can present with a hypotension and hypoperfusion, but sometimes it can occur in a normal vital signs. So there must be a balance between oxygen delivery and oxygen consumption in the body. Whenever this balance disrupts, there will be a chance of shock. Then how we will say this patient or the current which situation is in shock? The systolic blood pressure should be less than 90 mm of Hg for more than 30 minutes, or inotrope used to maintain systolic blood pressure more than 90 mm Hg. Then second point is evidence of end organ damage, in which we can assess the altered mental status of the patient, urine output less than 30 ml per hour, or there will be a cool extremities of the patients. Then we see the laboratory parameters, in which metabolic acidosis, elevated serum lactate, elevated serum creatinine, these all the parameters will subject patient to the with shock. Then the classification of shock, we have overall 4 types of shock, in which hypovolemic shock, distributive shock, obstructive shock, and cardiogenic shock. So in middle of the circle, we already define the shock as imbalance between oxygen supply and oxygen demand. So outer borders reflect the systems of the body which contributes to the particular shock. That is hypovolemic shock includes body fluid, blood and fluid compartment. Distributive shock refers to the vascular system. Obstructive shock refers to the circulatory system. Heart refers to the cardiogenic shock. So in hypovolemic and distributive shock, there will be either volume loss or volume shift in the body. So in hypovolemic shock, there may be a hemorrhagic shock, traumatic hemorrhagic shock, hypovolemic shock, and traumatic hypovolemic shock. In this, hemorrhagic shock will cause the whole blood loss, and traumatic hemorrhagic shock also causes the whole blood loss. But how will we differentiate the hemorrhagic and traumatic hemorrhagic shock? So in traumatic hemorrhagic shock, there will be a presence of major soft tissue injury. In hypovolemic narrower sense, there will be a diarrhea and vomiting, from which there will be a loss of fluid, or there may be a diabetes insipidus like conditions. There will be a body fluid losses. And in traumatic hypovolemic shock, we can have polytrauma or road traffic accidents will cause the plasma loss. Then in distributive shock, there will be a two types of mechanisms in which there will be a regulation, tone regulation impairment or a permeability impairment. In that distributive shock, we have septic shock, anaphylactic or anaphylactoid shock, and neurogenic shock. In obstructive shock, it might be determined by preload by various locations. In that, there will be a obstruction in circulation. Then there will be a, determined by afterload or might be determined by right heart failure. Then in cardiac shock, we have myocardial pump failure, brady and tachyarrhythmias, acute insufficiency or decompensated stenosis. Then epidemiology. Most common form of shock among patients admitted to the intensive care unit is septic shock, followed by cardiogenic and hypovolemic shock. So whatever the patients come into the ICU, the most common cause is distributive shock, which is 62%. Then we have cardiogenic shock 16%, hypovolemic shock 16%, and obstructive shock is 2%. Then distributive shock. In distributive shock, there is a widespread vascular dilatation associated with the release of inflammatory mediators. We can see the vasodilation here. Typically, it is mainly observed in sepsis, but also occur in anaphylactic or spinal shock. Some endocrinological disorders such as thyroid and adrenal crisis can also cause the distributive shock. Then next we have hypovolemic shock. This is due to the decreased circulating blood volume, occurs when there is an acute loss of 15 to 20% of circulating blood volume. So due to the loss of this blood or plasma, there will be decreased in the circulating volume, and which will decrease the preload of the heart. So this is caused by an external loss of whole blood, that is due to the hemorrhage, or maybe a plasma loss due to severe burn, or extracellular fluid loss, severe dehydration, or loss of gastrointestinal fluid with vomiting or diarrhea. Then what is cardiogenic shock? In cardiogenic shock, there will be a ventricular failure. It is characterized by decreased cardiac output, hypotension, hypoperfusion, and indication of tissue hypoxia, despite of adequate intravascular volume. Here, volume will be okay, but the shock will be due to the impairment in the heart. It is due to the myocardial infarction, end-stage cardiomyopathy, advanced valvular disease, severe myocarditis, or severe cardiac arrhythmias. This might be a cause of cardiogenic shocks. Then obstructive shock, there will be a obstruction of blood flow through the central circulation. It may be caused by dissecting aortic aneurysm, cardiac tamponade, pneumothorax, arterial myxoma, massive pericardial effusion. Next, we will see the pathophysiology. So in vascular response, there is autonomic response activation in the body after shock. Then there will be a baroreceptor activation causes sympathetic system activation. In carotid artery, we have baroreceptors. Due to the activation, there will be a sympathetic system activation, and which will further increase the heart rate and contractility, and which will redistribute the blood flow to the vital organs. Then there will be a RAS and ADH, that is antidiuretic hormone, and renin, angiotensin, aldosterone system activation will be done by the body, which will inhibits the renal loss of sodium and water and help to maintain the intravascular volume. Then we have microcirculatory dysfunction. In normally there in patient there will be a good perfusion of oxygen in the body, but whenever there will be a patient in a shock, there will be reduced perfusion. Then there will be endothelial cell damage due to the glycocalyx alterations, activation of coagulation, and leukocyte and RBC alteration. These all will cause the microcirculatory dysfunction. Then we have cellular injury. Normally, ATPs are produced via aerobic glycolysis and tricarboxylic acid cycle, that is TCA cycle. In shock, due to lack of oxygen, pyruvate cannot enter the TCA cycle. So it is converted to lactate via aerobic glycolysis and released into the circulation. So due to this lactate release in the circulation, there will be hyperlactatemia we have seen in the shock. Persistent cellular hypoperfusion, ATP depletion, energy dependent cellular systems are impaired. Then inappropriate activation of the systemic inflammation causes cellular injuries, which leads to the multi-organ dysfunction. So there will be a systemic inflammation, which further leads to the multi-organ dysfunction in the shock state. Then, as per the etiologies concerned with the particular shock, we have pathogenesis like in hypovolemic shock, there will be decreased circulating blood volume. In septic shock also, we have decreased circulating volume, which further reduces the venous return to the heart. Then there will be decrease in the cardiac output, decrease in the blood flow, and decreased supply of oxygen, anoxia, and it further leads to the inflammatory mediators, which will cause the shock. In cardiogenic shock, there will be decreased, and in other types of shock, like traumatic or neurogenic shock, hypoadrenal shock, there will be decreased cardiac output, which will further lead to decreased blood flow, decreased supply of oxygen, anoxia, and ultimately shock. Then we'll see what are the hemodynamic parameters. So let's take a case, a 45-year-old female patient admitted to the hospital. Her blood pressure is 90 by 60 mmHg, heart rate is 110 beats per minute, and stroke volume is 60 ml per beat. So what will be her mean arterial pressure and cardiac output? So hemodynamic parameters, tissue metabolic requirements are met by both adequate mean arterial pressure and adequate oxygen delivery. So whenever there will be a oxygen delivery and consumption balance in the body, it will be due to the mean arterial pressure and oxygen delivery. So the mean arterial pressure is average blood pressure over a cardiac cycle. In a cardiac cycle, 1/3 part is spent in systole and 2/3 part is spent in the diastole. So in mean arterial pressure, we have systolic blood pressure into 1/3 plus diastolic blood pressure into 2/3. According to this, we will calculate the mean arterial pressure. So whatever will be the systolic blood pressure of the patient, will divide by 3 and plus diastolic blood pressure of patient into 2 by 3. So this will give us a rough calculation of mean arterial pressure. Then mean arterial pressure is depend on cardiac output and systemic vascular resistance. So cardiac output is again depend on the heart rate and stroke volume. Then stroke volume depends on the preload, afterload, and contractility. Then we have cardiac index, which we can calculate as cardiac output divided by body surface area. Then these are some hemodynamic parameters in which systolic blood pressure will be 100 to 140, diastolic blood pressure will be 70 to 90, cardiac output will be 4 to 7 liter per minute, and etc. Then we have Frank-Starling curve. So as we said, preload is left ventricular end diastolic volume. So whatever the blood comes in the left ventricular, that will be considered as a preload. Then cardiac performance. So cardiac performance will depend on the stroke volume or the cardiac output. So this Frank-Starling curve relates preload to the cardiac performance. Whatever the cardiac performance and the preload, it will give us the predictor of the both. So as we see in the graph, this middle point is operating point of heart. At this point, there will be a cardiac output equal to the venous return. So when there will be a decreased total peripheral resistance, that is in exercise, there will be increase in the cardiac preload and there will be increase in the stroke volume. And whenever there will be a vasoconstriction, that is increase in total peripheral resistance, there will be a decrease in the preload and decrease in cardiac performance. So next, hemodynamic parameters in shock. So in shock state, like in hypovolemia, we have decreased preload due to the decreased circulatory volume. Then due to that, there will be decreased cardiac output and there will be increased afterload. Then in cardiogenic shock, we have increased preload, but there will be a decreased cardiac output and increased afterload. In obstructive shock, we have increased preload, decreased cardiac output, and increased afterload. So there will be, in cardiogenic and obstructive shock, you have to differentiate whether it is a cardiogenic shock or obstructive shock depending on the etiology. Then in distributive shock or vasodilatory shock, pre-resuscitation state, we have decreased preload due to the vasodilation, decreased cardiac output due to decreased preload, and there will be a decreased afterload. Then in post-resuscitation stage, there will be increased preload. Due to that, there will be increased cardiac output, but there will be a decreased afterload due to the vasodilation. Then coming back to the questions, a 45-year-old female. So this will be a 70 mmHg and 6.6 liter per minute. Then moving on to the diagnosis part. So the assessment of the patient in shock, presumed circulatory shock, involves combination of clinical, hemodynamic, and biochemical signs. So whenever you want to diagnose a case in a shock, you need to think about clinical, hemodynamical, and biochemical signs. So first, clinical signs of the shock related to the poor perfusion, which includes cold, clammy skin, such as the result of vasoconstriction. There will be a cyanosis, decreased in urine output to less than 0.5 ml per kg per hour, and altered mental status due to decreased cerebral perfusion. So these three, that is altered mental status related to brain, motile clammy skin related to skin, and decreased urine output related to kidney, these three considered as three windows. Then there will be, second is hemodynamic signs of shock. In that you can have hypotension and tachycardia, decreased cardiac output in cardiogenic shock, hypolimic shock, and obstructive shock, but there will be normal or high cardiac output in distributive shock. In systemic vascular resistance, it is typically considered a distributive shock, but reduced in all other forms of shock. In biochemical signs, we have hyperlactatemia due to the anaerobic. In clinical scoring systems, so clinical scoring systems are algorithms which are designed to predict the outcomes of the patients. So in that we can have SOFA score or Apache score or Mu score. So SOFA is sequential organ failure assessment. Apache, that is acute physiology and chronic health evaluation. Mu, that is modified early warning score. So in SOFA score, we have parameters like respiration, then coagulation, platelets, liver, we have seen bilirubin. In cardiovascular, we see the hypotension. In CNS, Glasgow Coma Scale, and in renal, we have creatinine or urine output. So as per these scores, we define a patient in, that is, if the score is less than 2, there will be 100% survival, or if the score is more than 11, there will be 100% mortality. Then in Apache score, we have temperature, mean arterial pressures, heart rate, respiratory rate, oxygenation, acid-base balance. Then we have sodium, potassium, creatinine, and hematocrit, WBC counts, GCS, and there will be points related to total acute physiology scores, age points, and chronic health points. So in this, there will be a minimum of 0 score and maximum of 71. So there will, as the score increases, there will be increase in the risk of the death. In modified early warning score, we have respiratory rate, saturation, heart rate, systolic blood pressure, urine production, temperature, and consciousness. So here, if the score is 0 to 1, which is low, it will give us a low value. And if the score is more than 5, there will be increased risk of mortality. So as the score increases in all the systems, all the scoring systems, there will be a high chance of increasing mortality. Then moving on to the management. So in the management of shock, we have to act like VIP, that is ventilate, infuse, and pump. So oxygen must be administered immediately to correct the hypoxemia. Then we need to infuse the fluid administration, that is it is a cornerstone in the management of patient with shock, aimed at increasing cardiac output and improving the tissue perfusion. Then third is the pump, that is in majority patients with shock, vasoactive agents will require to help the restore adequate perfusion pressure. So vasoactive agents includes vasopressin, noradrenaline, etc. So first step is fluid resuscitation. So in fluid resuscitation, the choice of fluid should be considered. Whatever the fluid you are considering must be good for the patient. It must be cost uh, benefit. Then there are two types of fluids, in which crystalloids and colloids. So first is crystalloid. It is an aqueous solution composed of water and small solutes such as electrolytes and glucose, in which we have hypotonic, isotonic, and hypertonic solutions. Hypotonic solution is 5% dextrose. Isotonic, we have 0.9% saline, RL, plasma light. In hypertonic, we have hypertonic salines 3% or 7.2 or 7.5%. Then in colloid, it is a large molecule weight particles such as proteins or hydroxyethyl starch suspended in a colloid solutions. There are two types, natural and synthetic. So natural, it will be from whole blood, plasma, or albumin. In synthetic, it will be from gelatin, starch, dextrans, or complex polysaccharides. Then we'll see the compositions of crystalloid solutions. So in normal saline, it is isotonic, that is osmolality is around 308. The blood osmolality is around 275 to 295. So pH is 0.5, sodium 154, and chlorine is 154 in normal saline. In RL, compound sodium lactates, osmolality is around 280, sodium content is 131, chlorine is 111, and lactate is around 29. In Ringer lactates, osmolarity is around 273, pH is around 6.5, sodium content is 130 millimole per liter, potassium 4, chlorine 109, and calcium is 2.7. And the lactate present in the Ringer's lactate is 28% millimole per liter. Then in Ringer acetate, there will be a acetate present in 24 millimole per liter, malate 5 millimole per liter, and magnesium 1 millimole per liter. Then in crystalloid solutions, next are plasma light, 5% glucose in water and 4% glucose in 0.18% saline. Then next is colloid solutions. In colloids, we have albumin 5%, 20%, 6% hydroxyethyl starch in saline, and polygelatin. In this, osmolality of albumin 5% is 260 and albumin 20% is 130. Sodium 130 to 160 in 5%, and chlorine is 125, and octanoate is 8 millimole per liter. In albumin 20%, there is sodium is 48 to 100 millimole per liter, and octanoate is 32 millimole per liter. Then next is vasopressors and ionotropes. So noradrenaline, initial dose must be 5 to 15 microgram per minute. You can start with 0.05 to 0.15 microgram per kg per minute. In cardiogenic shock, it will be 0.05 to 0.05 microgram per kg per minute. Maintenance dose will be 2 to 80 microgram per minute. In cardiogenic shock, it will be 0.05 to 0.4 microgram per kg per minute. Maximum dose can be used up to 250 microgram per minute, that is 1 to 3.3 microgram per kg per minute. It is a vasopressor of choice in septic, cardiogenic, and hypovolemic shock. The next is adrenaline. Initial dose 1 to 15 microgram per minute. Maintenance dose will be 1 to 40 microgram per minute, and maximum dose will be 160 microgram per minute. It is the vasopressor of choice in anaphylactic shock. It will be an add-on agent to noradrenaline or other vasopressor to increase the mean arterial pressure. Then we have phenylephrine. Initial dose must be 40 to 160 microgram per minute until stabilized. Then maintenance dose range is 20 to 40 microgram per minute, and max dose is 730 microgram per minute. It is a pure alpha adrenergic vasoconstrictor, so there may be chances of tachyarrhythmia. So it may decrease the stroke volume and cardiac output in patients with cardiac dysfunction. Then we have dopamine. 2 to 5 microgram per kg per minute will be the initial dose. Maintenance dose will be 2 to 20 microgram per kg per minute. And in refractory shock, there will be maximum dose used 20 microgram per kg per minute. It is an alternative to noradrenaline in septic shock in highly selected patients where the absolute or relative bradycardia, or there will be a low risk of tachyarrhythmia. Then we have vasopressin. Initial dose will be 0.03 units per minute. Maintenance dose will be 0.01 to 0.04 units per minute. Maximum dose will be more than 0.04 units per minute, can cause cardiac ischemia and should be reserved for only salvage therapy. This will be an add-on agent to noradrenaline to raise the BP and target mean arterial pressure or decrease noradrenaline requirement. It is pure vasoconstrictor and can decrease stroke volume and cardiac output in myocardial dysfunction. Then we have dobutamine. It is an agent of choice in cardiogenic shock with low cardiac output and maintaining BP, increased cardiac contractility and rate. In milrinone, it is increased contractility and rate. It needs dose adjustment in renal impairment. Then some pharmacology regarding these vasopressors. So adrenaline, which is used in cardiogenic shock with hypotension, vasoplegic shock, bradycardia, anaphylaxis. Side effect will be hypertension, skin necrosis with extravasation, myocardial ischemia, tachycardia, arrhythmia, increased lactate. It have more activity on beta 1, some activity on beta 2, and on beta alpha 1. So due to the beta 2 activity, there will be increased lactate levels. In noradrenaline, it is mostly used in cardiogenic shock with hypotension, vasoplegic shock. Side effects will be hypertension, skin necrosis, extravasation, and arrhythmia. It have more action on alpha 1 receptor. Dobutamine reserved for cardiogenic shock. Tachycardia will be the side effect, myocardial ischemia, ventricular and arterial arrhythmias. Then dopamine, it have a limited utility in shock. Tachycardia, arrhythmia, mesenteric hypoperfusion will be the adverse effect. It has more beta 1 action. Then some hemodynamic effects of these vasopressors. So dopamine will increase the cardiac output, cardiac index, systemic vascular resistance, pulmonary capillary wedge pressure, mean arterial pressure, and heart rate. Dopamine will have more effect on the cardiac output. Adrenaline, as it acts on beta 1, beta 2, and alpha 1, so there will be increased cardiac output and mean arterial pressure and heart rate. Milrinone, there will be decreased systemic vascular resistance. Noradrenaline will cause increased systemic vascular resistance and increase in the mean arterial pressure. Phenylephrine will have increase in systemic vascular resistance and mean arterial pressure, but it have selective alpha 1 action. And vasopressin will also have effect on the mean arterial pressure, but it will be used as an add-on agent with noradrenaline. Then we have complication of vasopressor therapy. So noradrenaline will can cause extravasation, which can be treated with alpha blocker, that is pentolamine. Then there will be a reflex bradycardia and vasoconstriction leading to the ischemia and infarction. The next is adrenaline. It can cause mesenteric ischemia, tachyarrhythmias, hyperlactatemia due to the beta 2 receptor activity, which can cause the glycolysis. Then phenylephrine, there will be reflex bradycardia, splanchnic ischemia. In dopamine, we can have increased heart rates and tachyarrhythmia. In vasopressor, we have cardiac arrhythmia, splanchnic vasoconstrictions, and ischemia and peripheral necrosis. So, to summarize diagnosis and management of the shock, we can define shock as hypotension, that is systolic blood pressure less than 90, mean arterial pressure less than 65. Then tachycardia will be there, more than 100 beats per minute, oliguria, altered mental status, elevated lactates, Q-SOFA and SOFA scores. These all give us a diagnosis of the shock. So first, we have to prepare for the patient who is receiving as a shock. Full set of vital signs, establish intravenous or intraosseous access. Then there will be a room setup in which ultrasound port cart, patient on monitor. There will be a 12 lead ECG. Ensure adequate support of senior staff. Then second will be readily reversible causes, in which tension pneumothorax, pericardial tamponade, and anaphylactic shock, which can be readily reversible. If the patient is in anaphylactic shock, intramuscular epinephrine will be a drug of choice. Then third, we have stabilized and survey. So we have to look for ABC, airway, breathing, and circulation. Then survey for the abbreviated through obvious external hemorrhage. Then consider the EFAST exam, in which flat IVC will less likely in obstructive shock and more likely in hypovolemic shock. Then assess the tension pneumothorax, tamponade in the patient. Then establish central access. Then we have to look for the workup, in that chest X-ray, ECG, blood cultures, ABG, VBG, lactates. Then we can have coagulation status of the patient. And at last, we have analyzed and reversed the following causes like obstructive shock, hypovolemic shock, cardiogenic shock, and distributive shock. In obstructive shock, there will be a distended neck veins, dilated IVC, cardiac. In cardiac, we can have constrictive pericarditis, pericardial tamponade. And if it is related to pulmonary, there will be acute pulmonary embolism and tension pneumothorax. In hypovolemic shock, there will be a dry, flat, collapsible IVC, that is in inferior vena cava. Hemorrhagic shock, there will be a transfuse of blood. In non-hemorrhagic shock, there will be aggressive fluid volume resuscitation. Then in cardiogenic shock, which can cause due to the myocardial ischemia, arrhythmia, valvulopathy, diffuse crackles will be there, elevated jugular venous pressure. Then in distributive shock, in septic shock, there will be aggressive intravenous fluid administration and antibiotics. In anaphylactic shock, there will be intramuscular epinephrine, as we already said. And in adrenal sufficiency and adrenal insufficiency, there will be a corticosteroid administration. Then we have questions. A 67-year-old female smoker presented to the emergency department. She was clammy, confused, and oliguric. Arterial blood gas taken while receiving oxygen at high flow via a face mask showed severe hypoxia and lactic acidosis. Lactate were 7.5 millimole per liter. Her mean arterial pressure was 45 mmHg. White blood counts were 28,000 and CRP were 452 mg per liter. What clinical signs will you look to diagnose this type of case? So we'll look for the clammy, confused, and oliguric status of the patient. Then severe hypoxia, lactic acidosis, which has lactate levels 7.5, decreased mean arterial pressure, which was 45 mmHg, increased count up to 28,000, and increased CRP. This is a probable case of a septic shock. In this, our main factors are lactate increased, WBC count has been increased, and mean arterial pressure was decreased. The next question is, a 55-year-old male patient was admitted to the hospital with the history of chest pain for about 3 hours. He was drowsy, extremities were cold, and his blood pressure was 84 by 60 mmHg. His ECG showed an anterior ST elevation myocardial infarction. So what provisional diagnosis you will think in this type of case? So here patient have cold extremities, decreased blood pressure, and there is ST elevation myocardial infarction. So this is a case of cardiogenic shock. So next is, a 56-year-old man presented to emergency department complaining of epigastric pain. Episode of hematemesis at home prior to arrival. He is a known case of alcoholic cirrhosis, hypertension, and diabetes mellitus. On examination, his temperature is 37 degrees Celsius. Blood pressure was 110 by 75 mmHg. Pulse 98 beats per minute. Respiratory rate 18 beats per minute. And oxygen saturation is 98% on room air. A CBC showed HB of 8.8 gram per dl. Later, patient found diaphoretic and disoriented after having an episode of hematemesis in the bathroom. So repeat vital signs are blood pressure 70 by 40, pulse 128 beats per minute. So which of the following is most appropriate next step in the management? Whether it is 1 liter of IV normal saline, 1 unit packed red blood cells, IV ceftriaxone, or IV pantoprazole. So here he had an hematemesis episode. His HB count was 8.8 gram per dl, and vital signs were the blood pressure was decreased 70 by 40 and pulse 128. So this is a possible case of hemorrhagic shock. So we will give 1 unit packed red blood cells to this patient. So the key takeaways: acute circulatory failure demands prompt diagnosis and urgent resuscitation. Hypovolemic, cardiogenic, distributive, and obstructive, these are the main 4 types of shocks. The management of shock include identifying and treating acute reversible causes, administration of intravenous fluids and vasopressors, mechanical ventilation wherever necessary till the recovery. These all the parameters we need to check time to time. Every vasopressor agent have a different role in the management of shock. Noradrenaline is preferred in vasopressors preferred as a vasopressor agent in cardiogenic and septic shock, while dobutamine is preferred in inotropic agent. So whenever there will be a decreased cardiac output, you can use the dobutamine in that patient. So these are some references. So the next uh, presentation of basic model in infectious diseases cycle 2, that is optimizing pharmacokinetics via antibiotic infusion, intermittent versus extended versus continuous, on April 5th, 2024, 6:30 p.m. to 7:30 p.m. by the Grace Mary John ma'am. Next, presentation 3 of basic module infectious diseases cycle 2 on antimicrobial dosing in patients on renal replacement therapy on April 9th, 2024 at 6:30 to 7:30 p.m. by Grace Mary John ma'am. Thank you. Any questions?
Thank you, Shivam. Thank you for providing a very clear roadmap about shock to our audience. So I have one or two questions. Actually, the last and the fourth question was very intriguing about the hemorrhagic shock. So I was puzzled which one to choose. I have one question. Why do we have a limited utility of dopamine in shock?
Dopamine have limited role in shock due to its action on the dopamine receptors. There will be a in trials we did not show any significant results in shock.
Okay. So more of that, it has less clinical effect
Like clinical
in shock.
effects on in shock. Right.
Okay. And are there any guidelines that recommends the appropriate dosages of these ionotropes and vasopressors for shock that we can use as reference?
There are no specific guidelines, but some of the guidelines says that there is no limit of vasopressor, maximum dose of vasopressor. So we can use the whatever dose we can exceed up to as per the patient tolerance.
Okay. So we can refer to the various trials for these vasopressors.
Yeah.
Okay. Okay. Thank you, Shubham. I hand it
Thank you.
over to the official handle. Thank you for joining.